The human brain processes millions of sensory data points every second, but under conditions of stress or extreme fatigue, this processing engine begins to misfire. In clinical psychiatry, this specific misfire is known as an illusion. It is defined precisely as a misinterpretation of a real, external stimulus. A person walking in the dark might look at a coiled rope and perceive a snake. A patient might hear the wind rattling a window and perceive someone calling their name. Medical boards test this concept using a simple mnemonic: real but wrong. The physical stimulus exists in the environment, but the brain's interpretation is incorrect. This is entirely distinct from a hallucination. A hallucination is a false perception generated entirely internally, with absolutely no external stimulus present.
Understanding this distinction requires us to map the diagnostic matrix, deconstruct the three clinical typologies of illusions, and establish the specific etiology-driven nursing protocols used to treat them. Failing to accurately diagnose this difference can lead a clinician to misclassify an environmental processing error as acute psychosis, triggering a dangerous, incorrect treatment pathway. This diagnostic decision tree for sensory disturbances begins with a central node that forces the clinician to ask one question: is an external stimulus present? If an external stimulus exists in the room, the sensory disturbance routes down the present pathway, confirming an illusion. If there is no external source for what the patient sees or hears, the diagnosis routes down the absent pathway, confirming a hallucination. Once the stimulus is identified, clinicians use a second diagnostic toggle: the capacity for patient correction. When a patient experiences an illusion, a clinician can usually point out the physical object, like turning on the lights to show the coat rack, and the patient will recognize the error. Their perception corrects itself. Hallucinations resist logical correction. Because the perception is generated internally by a pathological process, no amount of environmental evidence will convince the patient that the stimulus isn't there. Illusions occur across both healthy individuals and patients with mental illness. Hallucinations are almost exclusively markers of severe psychiatric or medical pathology. Relying on these two binary toggles, stimulus presence and correction ability, allows practitioners to make rapid, objective diagnostic decisions in high-pressure clinical environments. This three-column framework illustrates that illusions do not all stem from the same neuropsychological failure. They fall into three distinct clinical typologies. The first column details affective illusions. These are directly driven by heightened emotional states, primarily fear and severe anxiety. A highly anxious patient lying in a dark room might perceive a shadow cast by their coat as an intruder approaching their bed. The intense fear overrides accurate sensory processing. The second column covers completion illusions. The human brain uses predictive processing to operate efficiently, anticipating inputs to save metabolic energy. When reading an incomplete sentence, the brain often prematurely fills in missing letters based on past experience. You perceive a complete word that isn't actually printed on the page. The final column is pareidolia. This is the psychological tendency to extract meaning and project recognizable patterns onto vague, random stimuli. Seeing human faces in the shapes of clouds or picking out figures in textured wallpaper are classic examples of this mechanism. Unlike affective illusions driven by stress, pareidolia is largely a normal, non-pathological phenomenon built into human visual processing. Categorizing the specific type of illusion allows the clinician to look past the immediate symptom and isolate the underlying driver, whether that is anxiety, cognitive fatigue, or a normal pattern recognition function. This vertical spectrum illustrates the etiology of illusions. It occupies a unique space between benign environmental factors and severe systemic disease. At the top of the spectrum are normal causes. Low lighting, poor visibility, severe physical fatigue, and acute stress are the primary drivers here. Neurologically, these errors occur when an unclear, ambiguous stimulus meets a brain that is metabolically or psychologically exhausted and unable to process the data accurately. Moving down the spectrum reveals the pathological causes. Chronic conditions like dementia and schizophrenia, or acute states like substance intoxication, severely impair the brain's perceptual accuracy. However, the most critical pathological driver on this list is delirium.
ICU patients and elderly populations face the highest statistical risk for developing delirium-induced illusions. The sudden onset of illusions in an ICU setting is a high-yield diagnostic marker. It almost always points to acute delirium. Crossing this pathological threshold transforms an illusion from a trick of the light into an alarm indicating systemic medical deterioration. This four-step clinical pathway outlines how active management of an illusion must align with the real but wrong axiom. Step 1 is assessment. Clinicians first identify the specific illusion type and evaluate the patient's baseline consciousness and orientation. Step 2 targets the environment. The immediate intervention requires providing adequate, bright lighting and reducing ambient room noise. Because illusions require an external stimulus to exist, removing environmental ambiguity directly neutralizes the mechanism creating the symptom. Step 3 focuses on safety. Nursing staff must stay with an anxious patient to physically prevent panic-induced falls while the perception is corrected. Step 4 is definitive treatment. Medical intervention targets the underlying physiological cause, managing infection, reversing intoxication, or treating delirium. Proper nursing management of illusions relies entirely on sensory modulation and systemic root cause care. This represents a radically different protocol than the primary psychopharmacological approach used for hallucinations. An illusion is a failure in the interpretation of reality, not a total detachment from it. This single clinical boundary dictates the entire trajectory of patient care, from simple lighting adjustments at the bedside to the administration of heavy psychiatric medication. Accurate diagnosis requires a trained clinical reflex. Find the stimulus, clarify the environment, and assess pathology, like acute delirium. Mastering the real but wrong framework ensures clinicians do not just suppress a distorted symptom, but accurately identify and heal the patient experiencing it.